I gave this presentation to the oral surgery department when I was a PhD candidate in Gyeongbuk National University Dental School. The message of the presentation was how I practice implant dentistry in my private practice and the reason why. This is me when I was much younger. Let me introduce myself. I was born in Korea. I lived most of my life in Busan, which is located south part of the country. This is where my private practice was. I took over my father's practice and practiced dentistry until year 2014 when I left for endo training at USC. Let me give you my background. I came to the state when I was 16. I've got my DDS degree at UIC and a full-time implant residency at Loma Linda from year 2001 to year 2004. This is Loma Linda Hospital. And this is Loma Linda Dental School. One of the perks being a resident was that we had a guest speaker who came to the school or the department directly and gave us lectures and presentations. And this is where the implant department is located. Loma Linda Implant Residency Program is 3 years long. During that time, you learn both surgical and prosthetic disciplines in implant dentistry. Implant department has 6 operatories. This is where I learned implant prosthodontics clinically. Department also has 2 surgical suites. This is where I learned the surgical trainings. Photo on the left is me doing surgical procedure during the residency, and the one on the right is me doing the surgical procedure at private practice. I wanted to share with oral surgery residents the experiences and the lessons that I learned over the time that shaped and changed the way I practice implant dentistry. Implant dentistry has 2 components, surgical and prosthetic parts. The sequence is that after surgical step is completed, then prosthetic phase is followed. The sequence of actual implant treatment is that bone graft is the very first thing that you do if the plant site is not conducive for implants. Then implant surgery follows. A last step is implant prosthesis that completes the treatment sequence. So in reality, the bone graft is the first, implant surgery is next, then the implant restoration is the last in sequence. However, when you're planning an implant treatment, you need to plan final implant prosthesis at very first. Then you plan the rest of the procedures that can support the planned prosthesis properly. Your implant surgery plan consists of number of implants, location of the implants, and size of the implants, and so on, that satisfy the final prosthesis. Last step in treatment plan sequence is bone grafting procedure to meet the need of implant surgery plan. So the planning sequence is the actually opposite of the treatment. Prosthesis first, then implant surgery, then bone graft is the last in that order. There are so many kinds of implants available these days. However, I use only these 4 implants in my private practice in Korea. All the 4 implant systems that I use have these common designs: internal connection, conical connection, and platform switching or platform shifting. At Loma Linda Implant Residency, Nobel Biocare replaced external hex was the main implant system that I was trained initially. When the Nobel Biocare discontinued the external hex replaced implant, replaces select internal connection implant system became the main system that I learned. So let me share some of my Loma Linda cases. This is the case where I had to replace the tooth number 3. As I stated previously, implant treatment starts with final restoration first. Diagnostic wax-up on model was completed to plan the implant surgery. Surgical template was made for the implant. Implant at number 3 site is placed as planned. Routine implant prosthetic procedure is carried out. Final restoration was fabricated and it was delivered. When you start residency, you inherit cases from graduating residents. Some are ongoing cases that were not completed, and some are completed cases that you are following for the recall. This was a recall patient who had a crown loosening on implant 29, which had a cement retained restoration. Occlusal access was made through the porcelain and the metal substructure to retighten the screw. After the screw was retightened, patient became extremely upset because the patient claims that I ruined the perfectly good implant restoration. The patient made a huge complaint to the program director. After all the drama, we decided to remake the crown at free of charge. This was one of the experiences that shaped the way I practice implant dentistry and private practice. New custom abutment was made for a new crown. A jig was made to help to position the abutment in patient's mouth. Because the recurrence of screw loosening in the future could not be ruled out, lingual screw retained crown was made for this patient. In case the screw loosening happens again, crown disassembly is possible without cutting or drilling through the crown. This is another case that I inherited from graduated residents to complete the implant restoration in upper right side. Open tray impression with a custom tray was made, and this was the working model. I decided to take a little difficult path to restore these implants for experience. I chose to make lingual screw retain restoration, all splinted. My upper class resident taught me that making splinted 3 lingual screw retain implant restoration takes a really good precision, because if all the lingual screws are not properly lined up, the screws would not go in. He taught me that in some cases, cement rather than the lingual screws are used for restoration, because if the lingual screws do not go in, they cannot provide enough restoration retention. Abutment jig was made to orient the custom abutment and transfer them to the implant. The metal frame has to be cut and soldered because the lingual screws would not go in as it was made in the model. After the soldering, I was able to see the framework with the lingual screws in. Porcelain work was completed. Abutments were tightened to the recommended torque. After delivering the restoration with the lingual screws, I was so proud of myself that I was able to make such a precision restoration. But the patient was so upset with the restoration that I just completed. The complaint was that new restoration did not look like the one on the other side. Until that point in my career, I thought that aesthetic zone was from canine to canine. I never thought that premolar and the first molar would be considered aesthetic zone. I was completely wrong. I'm not the one who determines where the aesthetic zone is. It's the patient. If the patient thinks that first molar appearance is important, then it is part of the aesthetic zone, even though restoration cannot be seen until the cheek is retracted. The implant restoration was removed, and I have to remake the restoration. The photo on the left is the reason that I do not do lingual screw retain implant restoration at my private practice. I showed this photo to the upper class resident. He told me that because of this, sometimes cement is used in lingual screw restoration to provide a seal and potentially prevent the plaque buildup inside of the restoration. This time, provisional was used and modified until the patient was satisfied. New splinted 3 lingual screw implant restoration was delivered. The final restoration was tested through provisional phase until the patient's approval. Once the patient was satisfied, new restoration was fabricated based on the provisional this time. left is the first restoration, the right one is a new one. This was another experience that shaped the way I practice implant dentistry. One of the features of external hex in implant is to provide joint stability for the abutment. Typically, hex height is 0.7 millimeter. However, some implant companies make 1 millimeter height hex and claims that it can provide less screw loosening. Even though I was trained with external hex implant, I don't use external hex implant in my private practice because the interface joint for the implant and abutment is only 0.7 to 1 millimeter long. This is another case that I inherited from graduate residents to restore. For unknown reason, one external hex replaced implant and one internal connection replaced select implant were placed on this patient. If the height or the length of a connection provides joint stability, you can see how much internal connection has more connection length than external hex implant from the same company with the same diameter. Based on this connection length comparison, internal connection can have 4 to 5 times greater joint stability than external connection type. Internal connection type implants have more connection area than external connection type implant in general. So more connection area can be provided for higher joint stability. Implant connection type can be also classified into butt joint or conical joint. External hex connection is an example of butt joint connection, while most of internal connection implant in today's markets are usually conical joint connection type. In butt joint connection, screw is the only mechanism that holds the abutment and implant connection together. Screw preload, which is springiness of the screw that clasps the abutment to the implant. When the screw preload is lost, abutment loosening can happen. In conical connection, screw preload helps to hold the abutment and implant connection joint. In addition to screw preload, friction between the abutment and the implant also helps to stabilize a conical joint. There are two components in conical connection. Screw preload and the friction play the roles in joint connection stability. When the screw loosening happens, it occurs unexpectedly. It can disrupt your daily schedule and make the entire situation very stressful. In implant literatures, most of screw loosening occurs within 1 to 2 years after delivering the implant restorations. Let me go over the article that I was a co-author of to explain why I do not use butt joint implant connection in my practice. In the article, we look into what the surface coating on the abutment screw affects on implant abutment joint stability, as well as differences in butt joint and conical joint. 3 commercially available Korean implant systems were chosen for the study. Implant and the abutment were tightened to the same force. Then 1 million cyclic load were applied at 30-degree angle. The key point of the study is to compare the screw removing torque before and after the loading in butt joint and conical joint implant system. We also compare the screw surface coating effects on the removing torque before and after the loading. These are the results. In all implant systems, it took less forces to remove the abutment screw after the 1 million cyclic load than before. Surface coated screw required higher torque to remove than non-surface coated screws in all implant systems consistently. We investigate the net loss of screw preload in different implant abutment joint connection systems. Butt joint implant system had statistically higher preload loss than 2 conical joint connection systems. Conclusion of the study is that conical connection significantly helps to increase the joint stability between the implant and the abutment against the loading. Also, the surface coating on screw increases the joint stability, meaning less chance of screw loosening can happen in conical joint connection implant system than butt joint connection. Conical connection also found to have biomechanical advantage in implant literatures. In Hansen's study, flat top, same as butt joint connection, was compared to conical connection. Result of the study was that conical connection decreased the peak stress at bone to implant interface, and it also helped to move the peak stress more apically than the flat top or butt joint connection system. Meaning, conical connection can potentially decrease the bone loss that happens around the implant than the flat top or butt joint implant system. Platform is also known as a platform shifting or platform mismatching. Personally, platform switching plays far more important role biomechanically in implant connection than anything else. A finite element analysis study by Maeda in 2007 looked into the effect of platform switching on bone implant contact area. In this study, only the platform switching on peak stress in bone implant interface was compared to non-platform switched model, or described as normal model in the experiment. In the study, a platform switching model did not have conical connection as previous Hansen study. The result of the study is that in platform switching model, peak stress takes place away from the bone to implant contact area, whereas normal connection has the same diameter as the implant, peak stress occurs at the bone to implant contact area. Conclusion of the study is that platform switching moves the stress concentration away from the bone to implant interface, but at the same time, it can increase the stress to the abutment and abutment screw. Platform switching also has a biological advantage. Because the abutment diameter is smaller than implant, more biological width can be established. More soft tissue seal at the seen at the red arrow on the photo can be present. This is one of the implant system, Ankylos, that uses a platform switching. As the circle on the photo says, that space for biological width can be found. More mismatching diameter of the abutment to the implant, more space for biological width can be established, thus decreasing the bone loss around the implant. This is another illustration from the Ankylos implant system that greater thickness of soft tissue can be present when platform switching is used. More soft tissue meaning there is a greater resistance to recession. Another biological benefit of platform switching is ICT, inflammatory cells infiltrate, which are always present at the junction between implant and abutment, has less effects toward the bone. On the left, non-platform switching situation, ICT, which you presented in red, has effect in this direction, whereas the right, that has a platform switching, ICT has less effect toward the bone, thus minimizing the surrounding bone loss. This is a scanned photo from Lazarus' article that regular implant connection, where platform switching is not present, bone level is typically seen at first thread, which is a more apical bone level than platform switching implant. Bone level with the platform switching is located closer to the implant platform, which indicates less bone remodeling and less bone loss. So in my private practice, the main implant system that I use have platform switching and conical connection and internal connection. Let me share a few of my private practice clinical cases. I start with diagnostic workup that help me to plan the final restoration. Then surgical planning is formulated and carried out to support the prosthetic plan. Then prosthetic phase starts with provisional to make sure that initial prosthetic plan can be properly executed. If any deviation from the plan has occurred, I need to determine what kind of adjustment can be made or if any adjustment can be possible before the final restoration. Once the provisional stage is met with evaluation criteria, meaning once the patient is happy with the provisional and I'm okay with the provisional, then the final restoration is fabricated as the provisional. Another benefit of going through provisional restoration is that I have another opportunity to check the screw tightening. Some screw preload is lost due to settling effect. Thus, clasping force or springiness of the screw is lost in time. When actual loading takes place, potentially more abutment wedging can occur. I typically tighten the screw at recommended torque at least twice, at the time of the provisional restoration and at the time of final restoration delivery, to ensure that screw preload is maintained or to re-establish the recommended screw preload if there has been any loss. Let me share you more of my cases. This is where number 30 was lost. Implant was planned for the replacement of the missing tooth. At the beginning, diagnostic workup was done on a model to plan for the final restoration. Based on the diagnostic workup, a surgical template is fabricated. Typically, I use this type of surgical template, meaning that suck down is used and acrylic is filled in the void, and the screw hole or the area where the implant needs to be are planned. Occasionally, I use just a suck down only to help to ensure that my implant location is properly maintained. This is a case where the flap was reflected, and one of the surgical template is used to prepare the initial osteotomy site. As the osteotomy site is progressively got bigger, the other type, suck down, can be used to make sure that I'm not deviating too much from the initial site. Implant is placed as planned, and this is how the implant look after it's been seated all the way. Again, suck down was used to make sure that I haven't deviated too much from the plans area. This is how the implant looked, and there was dehiscence on the buccal side. Membrane was positioned and bone graft was placed, and the membrane was reflected on the other side to protect the graft. And another tack was used to stabilize the membrane. And primary closure was made. Let this one area heal, and this is about 4 months after. And healing abutment was replaced, and soft tissue were reapproximated. This area was healed about a month or so, and this is how the healing looked. And this is the final restoration. And I don't have photos that's going through the provisional. Once the patient has gone through the provisional and the final restoration wasn't fabricated according to the provisional, and the final restoration wasn't delivered. This is another case. This is a case where I have to do a sinus augmentation. Lateral approach on the upper left hand side with the augmentation was carried out, and the implant and the sinus augmentation was done at the same time. This area was healed about 6 months, and this has gone through the provisional on the upper left hand side, while the upper left hand side has gone through the provisional. Same approach on the upper right side has been carried out. Again, this is the area of both upper left and upper right that has gone through the provisional. Let me show you another case. This is a case where upper left hand side was planned for sinus graft, and lower right hand side was planned for guided bone regeneration. We started with the lower right hand side because the residual ridge was thin. The residual bone had some decorticization to induce bleeding. Membrane was fixated and graft was done, and then also lingual side was stabilized with the bone tack. Healing took place about 6 months, and this is how it looked once re-entry was made. The implant were placed as planned. The implant were allowed to heal for about 6 months. Then it went through provisional stages. While the lower right-hand side has gone through the GBR phases, upper left-hand side went through the sinus graft as planned. Because I was able to stabilize the implant, sinus graft and the implant placement were carried out simultaneously. While we were waiting for the healing of the upper left-hand side, patient developed problems on the existing premolar. So that premolar, number 13, were extracted and additional implants were placed. And just like the lower right-hand side, it went through the provisional phases and the final restoration was completed. Let me show you another case. This is another case in a posterior mandible. The residual bone has some deficiency. So guided bone regeneration was started and primary closure was made. Re-entry was made about 6 months after, and this is where the site looked. And 2 implants were placed as planned, and this one was healed for about 4 months. Just like the other cases, it went through provisional and final restoration is completed. Another case. This is a patient who had a complete edentulous mandibular area and wants to have fixed restoration. 6 implants were planned and fixed implant partial denture or fixed bridge was planned for the final. As planned, there were 6 implants placed, and about 6 months later, provisional phase started, and impression was taken, and provision was fabricated in a lab. And this is a jig, and the provision was made. Provision was delivered and tested. Once the patient was happy, and I was reasonably happy with the restoration, final restoration was carried out. Final case. This is a case where sinus augmentation was planned on upper right and upper left, and number 10 had a hopeless prognosis, so decided to replace it with the dental implant. And also lower right and lower left side was planned for the implant, but again both lower posterior area were lacking bone, so guided bone regeneration was planned. And the upper right side patient had enough residual bone, so rather than external approach, internal sinus lifting was performed and placed 2 implant. Whereas the upper left-hand side, compared to the right side, didn't have enough bone for internal lifting, so lateral approach sinus graft was carried out and grafted. And because I was able to establish primary stability, 2 implants were placed simultaneously. An additional graft was done with the membrane and let this area heal. While the upper sides were healing, because the number 10 had a problem, tooth was extracted, the extraction socket was cleaned, and immediate placement was placed. I will address the criteria that I use in terms of implant position in immediate extraction socket. Once the implant was stabilized, graft was done, and the healing was allowed it with a customized healing abutment once the covers group from the previous photo was removed. Adjacent tooth was etched and tooth-borne provision was fabricated. On lower side, just like the other cases, mandibular posterior area had a very thin knife edge residual bone. with non-resorbable membrane and bone graft was used to augment that deficiency. Primary closure was made. Let this area heal about 6 months. Again, 6 months later, re-entry was made and the membrane was removed. And this is how much bone was regenerated. Implants were placed using the surgical template. And there was a little bit of more deficiency on the area. Graft was done. Let this area heal for additional 4 months. While the other was a healing, again, the opposite side went through the similar treatment. Thin knife edge was grafted with the bone graft and the non-resorbable membrane. Primary closure was achieved. And about 6 months later, re-entry was made. Remove the membrane with the stabilizing screws. And this is how much bone was regenerated. And 3 implants were placed as planned. While all these things were going on the lower, number 10, the provisional phases started. And this is how the provisional looked. And the final restoration was delivered. And the remaining part of this area where the implant were placed went through the provisional phases, and final restoration was completed. And I was able to follow this case about 3 years. Actually, I followed up to 5 years before I left. Everything seemed to be very stable. The main message that I like to convey to the listener is that as I emphasize the importance of planning prosthesis on this slide previously, that take-home message is that implant is prosthetically driven discipline. That it starts with prosthetic planning, it ends with prosthetic delivery. Again, thank you for listening my voiceover presentation.